Welcome to 1202, the Human Factors Podcast. The podcast that covers all things about humans, technology, and particularly the bit in between.
And welcome to this episode of 1202, the Human Factors Podcast. Today we're exploring human factors in the healthcare sector again, but this time a slightly different approach. We're now looking at this from a US perspective and really trying to investigate, does a different country make a difference how we apply human factors in the healthcare sector, and whether any of the problems rooted in the healthcare sector are country specific or are there wider issues to address. For many human factors practitioners, today's guest will be a familiar name, either for the number of publications that are out there that you'll have no doubt referenced at some point or other, or just listening to the number of keynotes they've given out, or if you're on social media, seeing his commentary and discussing all things human factors and offering advice and opinions and seeing how other people survive under the onslaught of knowledge. It gives me massive amounts of pleasure to welcome Ken Catchpole to the podcast today. Ken, welcome, and thank you very much for joining us.
Thank you. Thanks so much, Barry. That's a wonderful introduction.
It's we only go for the truth here. It's fine. For those of you who may not be familiar with you, and quite frankly, how dare they? So more speaking to people outside of the human factors domain. Who are you? What is your current role, and what do you do on a day-to-day basis?
So my current role is the Smart State Endowed Chair in Clinical Practice and Human Factors at the Medical University of South Carolina in the Department of Anesthesiology and Perioperative Medicine. What I do is a combination of kind of research and practice of healthcare human factors. Here at the Medical University, embedded within the clinical system. So I get involved in all the root cause analyses. I get involved in in quality improvement, and I also do human factors related research, where the hospital is my laboratory. And so it's an incredibly rich way to understand how to apply human factors principles within an acute healthcare system.
So that sounds like you get a real blend of actual hands-on activity, but also being able to research out to look at other things and look at root cause in that way. Is that that must be fairly unique positioning with what you're doing, isn't it?
Yeah, it's definitely deliberate, because I feel like there's value in both things, that we can apply human factors principles to improvement, to give perspectives on incidents or on kind of near-term improvements, and also get to explore some of the more persistent problems through research that we might have, that might take longer to explore and to test different approaches and that kind of thing. It's a very, very rich way to do it, and it's an unusual kind of position, I guess, but it's very important for me that it is like that.
So that sounds like you've almost engineered that sort of approach to be able to get to where you are. Is that so? Was that a deliberate decision?
Yes, entirely. Yeah. Since being in my first job at Great Ormond Street in London, I recognised both how important human factors could be to healthcare safety and healthcare design, care delivery, but also how the danger of being too far removed from that. So you didn't see the incredible intricacies and complexities of everyday work. It's been very deliberate, and it's definitely been it's come with its challenges, because there has never been a kind of strict career structure to it. But I've been able to sustain this, and I've been doing it for 21 years now. So yeah.
Well, you mentioned your career there. How did you first get into human factors? Because many different people find it many different ways, don't they? So what was your golden moment?
I was originally given some careers advice. I liked both the science. This is when I was looking to study a degree. So I did my first degree in ergonomics at Loughborough, based on some careers advice that was a kind of combination of the fact that I like science, but also I like the, I like the kind of soft areas. So, fell into, psychology. I did a PhD in auditory perception, and applied to alarm design. And so it's kind of, I was bitten straight away because of this combination of science and people, really, and systems. And of course, once you start to see the world in this way, it's very difficult to see it in any other way.
That's true. So from getting that initial bitten by the bug and then getting all the way through to getting your PhD, what was your career path from then?
So then I went to work for, as it was, DERA. It's now Kinetic, Defence Evaluation Research Agency. And did a variety of projects. I didn't strictly want to pursue an academic career in those days, and so did some really cool stuff. For example, with X-ray screening at UK airports, and did that for about 3.5, 4 years, something like that. And then was looking for something new and applied for a job at Great Ormond Street looking at errors in surgery. And yes, and then that was and that kind of led me to where I am now.
So obviously Great Ormond Street and DERA and Kinetic, they're all UK based, but you're over there in the US. That's an awful big pond to accidentally find yourself over there. What was the draw over to that side?
My mum was from New Jersey, and so lived in the UK with my dad. So I've been in dual national for all my life. And so when I got the offer to move to the US in 2011, I'd moved. That it was kind of too good an opportunity to pass up. It came about through a combination of a study that I did that was very, very well received, and got quite a lot of international exposure, and a collaboration I'd started, with this with Cedars-Sinai healthcare system in LA. And so it was a kind of combination of knowing people, and then they encountered my work through another, this other route, and then so essentially offered me a job to come and do human factors there. And it was the right time in my life. I'd been at Oxford for 6 years, and in a way, by that time there was much more conversation about human factors, which was my original goal when I got to Great Ormond Street. Nobody knew anything about human factors and thought I was weird. By the time I got to a point in Oxford after being, doing this kind of work for 8 years or so, that I needed to, I felt like I was ready for the next stage. And so this offer came at the right time, and my mum was from the US. So and my uncle lived in LA. And so it was a great opportunity. And if somebody, why not? Life is about an adventure.
That sounds really cool. How did, I guess, from when I've interviewed people from stateside in the past, the appreciation of human factors is I believe a lot greater than it is over here in the UK. So with one of the other podcasts I do with Human Factors Cast with Nick Rome, their appreciation of things like UX and things like that seem to be a lot more established and a lot more developed. Do you think that is the case, or is that just a bit of a mirage from this side?
I think that, the US is just much bigger.
Yeah.
So you can find pockets of, of understanding and expertise. But also, there's still, there's still a lack of understanding in other areas. Speaking about the healthcare sector, definitely the spread of the idea of human factors, or if you like, the label of human factors, has been much quicker in places like Australia and the UK, because they're smaller and they can be driven by essentially a small number of people. And so when I got to the west coast of LA, when I got to LA, nobody in healthcare had any idea about human factors, and it felt like I was going back 5 or 6 years in the UK. So definitely the spread of the ideas,
Okay.
but the focus on engineering, I think, in the healthcare sector in the US has been much bigger. That there's been this view of human factors in the UK as being about non-technical skills and teamwork training. Um, Whereas in the US, there's much greater understanding. It's really about systems engineering. So
Right.
the kind of narratives. So in a way, the idea of human factors is much better known within the health system in the UK, but it's often misinterpreted. Whereas in the US, it's less well known, but when it is, there's much greater understanding that's really about systems engineering,
Yeah.
rather than just kind of behavior.
See, and again, this is almost one of them interesting discussions we keep on having on social media and things about what does human factors actually mean, and the different flavors that it has. But I guess we won't nail that one today, because every conference I seem to go to ends up in the bar with the same thing. What does human factors mean to you? So I guess that's true.
Yeah.
I guess I really am intrigued by the cross the pond views and things like that. Do you find that there was anything that you could bring specifically, having been educated in the UK and then going out to the US? Did you bring a different flavor to what they were doing over there, a different insight, or were you happy it was just great and you just cracked on?
Let's see. So I mean, that's difficult to disentangle from the fact that at the time I moved to the US, there were still not many people kind of doing this
Yeah,
thing
yeah,
that I do. Um, uh, and I think, let's see, yeah. So one of the things I encountered was, I think in the UK, we're much more willing to look at our faults, particularly our faults in the healthcare system.
okay,
So it's easier to have conversations about what's wrong within the UK health system than it is in some US
right,
hospitals. So, when I went to Cedars Sinai, who pride themselves on being one of the best hospitals in the world, and to a certain extent, I think that's probably true. It's an amazing hospital, but they had a lot of the same problems that I was seeing in the NHS.
okay, yeah,
And so when I started saying, well, yes, and I know you're having some of the same problems that I've seen before, that didn't always go down very well,
okay, fair enough.
because so I had to find a different way, and I've learned, I'm trying to learn to be more, more to break bad news to people in different ways. That so I learned a lot actually about how to, in trying to kind of yeah, to spin things more positively than we've got problems, we need to fix them. It's like, instead, oh, this is great, maybe if we did this we could improve it, we could get better.
Right.
So there was definitely kind of those sorts of definitely cultural differences from kind of the often rainy UK predisposition versus the sunny, everything's amazing,
Yeah, yeah,
California disposition. And so, so I definitely brought I definitely brought a perspective. I have thoughts about, I think our academic training is much stronger. We specialize in the UK much sooner. And so somebody coming out of a PhD or out of a degree program in the UK, it just has a higher level of specialist experience, I think.
right, okay,
And so, bringing that to, I've been very, very successful as an academic in publishing and research. I think partly because of the, a really solid background I had within my training as well. That's not to say, it's different. There's a, anyway.
yeah. No, I can see that. I mean, I guess the last question I'd ask now, before we go into the actual the healthcare bit in more detail, is you're obviously one of these rare people who have the original ergonomics degree, which now you can't get in the UK follow
Yes.
the money. And I think even in the US now, it's really quite difficult to do that. Yes, we can get modules and stuff. A lot of people suggest that specializing in things like engineering and then finding human factors is actually a good way to do it.
Yeah.
What's your sort of response to that, given the route that you've traveled?
I mean, I definitely think that's, if you like, a safer route, because you do engineering and you've got an engineering background, and then you can choose to go into human factors. And anyway, even if you don't end up in human factors, you've still got the.
Yeah.
I certainly felt that it suited me pretty much from day one. I did start as I was going to do engineering, and just didn't feel like I wanted to do 3 years of engineering. And so, yeah, I think it's a shame that we don't have an undergraduate course. I think there's room for both.
Yep.
Absolutely, it's if you've got more than one qualification, if you've got a degree and a master's, then then you're doubly qualified. But at the same time, I have never felt in any way disadvantaged by the fact that I don't have an engineering degree. Yeah.
I guess to flip that on its head, then, do you think the discipline as a whole is kind of losing out because we don't have people who are just coming? I guess purist is the wrong word, but being able to come through with the ergonomic science from bachelor level degrees. Do you think we're missing out as a discipline?
So I mean, so to me, it's all about. So there's a kind of the question we ask all the time, and actually in healthcare, is around like expertise versus spread. In other words, is it better to have there just aren't enough human factors people in the world. If you took every single human factors ergonomist in the world and put them into healthcare, there still wouldn't be enough to kind of deal with a lot of the challenges. And so some way we've got to spread this expertise more widely, in a way that does service to the discipline and the body of science that we've built up. But at the same time, acknowledging that not everyone has the time and capability to do a master's or an undergraduate. So to come back to to answer your question, I see it simply as getting how do we get more qualified human factors, ergonomists? How do we get more of them into the field? And so if more people are able to do masters, do engineering for a little while and then come into it through, that is a great route. And in a way, I think that's probably the route that most people take, but at the same time, if that means we're losing out on the opportunity to get people early and to develop their expertise early, then I think that's a shame. As I of course, when, as somebody whose life was profoundly changed by doing the ergonomics undergraduate course at Loughborough, that of course it's a shame for me to see it go. But I would frame it in terms of how do we manage the expertise and the spread of our profession, because if we don't do it, then it's going to be taken up by people who maybe not best qualified to make decisions about what is or isn't human factors or ergonomics.
No, that I think that's very fair, and I think your insight into that is spot on. It's similar to what a number of other people have said, and yeah, it's about what we deliver into things, rather than worrying about the intricacies of it.
Yeah, I mean, and my experience in healthcare is of course that healthcare is, I would say, is very, very different from other industries, and so we need, so people coming from healthcare is great, but we need to make sure, because they have, they have this, better clinical understanding, but at the same time, we need to make sure that they're getting the right and the level of training and understanding that they need. And I work with some amazing clinicians who also are absolutely totally get, the systems thinking and the way to approach human factors. And also I've worked with a lot of clinicians, who or encounter lots of clinicians who think they know what human factors is, and they don't. And so, yeah, that's the tricky thing, I think, to navigate, is how do we spread this expertise that can be incredibly valuable while maintaining some level of kind of quality.
Yeah, no, I think that's great. I think we're going to take a quick break, and then we're going to dive into healthcare itself. So we'll be back right after this.
You are listening to 1202, the Human Factors podcast. We wanted to take the opportunity to say thank you for your support. You can help further by rating us through your podcast provider, sharing us through social media, and telling your friends and colleagues. Let's work together in raising awareness of the value in putting users at the center of what we do.
And welcome back. And I'm here talking to Ken Catchpole about the differences or similarities in human factors within healthcare, particularly looking across the US, UK perspective. So, Ken, I guess the $1 million question, the one that if we could do it regardless of where we're at, it seems that healthcare for human factors practitioners is still just difficult. Even though we've got loads of specialists, and I've been privileged to interview a lot of people on this channel now who are involved in healthcare, but it still seems such a difficult beast to crack. Why do you think that is?
I
thought I'd start with the easy one,
Yeah. So, I mean, I have particular forthright views on this. One of which is, I think, so let's see. So one of which is that there's the encounter between two very different ways of thinking, and I sort of talk about the fact that if human factors ergonomics, if we want to change healthcare, then by its nature, it's going to have to change what we have to change what we do too. And so, that's one perspective. On another, kind of healthcare is very much a closed shop, in terms of, it's viewed that it's the people in it, and as an industry, it's unique, and there is absolutely reasons to say that that's the case. But also, I think it's I think that there's a view that, well, we in healthcare can kind of do anything, but nobody can do what we do. And so there's a sort of there's a wonderful book by Bob Weers about called Still Not Safe, who talks about what was really once we started to think about patient safety and kind of engineering and safety science and those sorts of things within healthcare, that Bob's argument is that the healthcare system kind of or the people within the healthcare system said, this is not how we want to look up. We don't want other people looking at ourselves. We want to do it ourselves. And so there's this kind of active exclusion of systems engineers, all the people who said, look, we can help, and they said, no, we can do it ourselves. And to me, the root of all of this is that the perspective that human factors and systems engineering and ergonomics bring to healthcare is such a profound change, because it's such a different way to see the world, that it brings into question an enormous amount of assumptions that the people within the healthcare industry make, such as, if you're trained as a clinician, that it's all about you and how hard you try and how much you specialize and how hard you work. And then a systems engineer comes in and says, yeah, but that device you use might, if you get it in the wrong function, might cause you to injure a patient and you won't even know about it. That's a really, really disturbing idea. And then when you start talking about complex adaptive systems rather than linear determinism, it starts. So in other words, the fact that that there might not be a direct relationship, direct relationship between treatment X and outcome Y, because of the people within the system who are adapting all the time to the stresses and strains of the organization, then it kind of pulls the rug out from underneath what is seen as the best clinical evidence. So it brings into question the idea that a randomized controlled trial is necessarily the best sort of evidence, or that we can even count things like errors and outcomes reliably to evaluate the best practices. So healthcare, unlike other industries, is very and this is a good thing, very focused on evidence and evidence base.
Yeah.
But actually, this kind of way of thinking brings into question what really is, evidence. So it challenges individuals, it challenges systems. It says errors aren't a property of individuals. It says that that harm is created, among other things, by the financial and organizational decisions that we make. And it says that the evidence base that we have, that might not be as solid as we think it is. And so all of these things are incredibly challenging for anyone in the healthcare industry who thinks what we do is evidence based, and it's all about how hard I try, and errors are only are from bad people, and that whatever the system I'm given, I should be able to function within that. And so all of those things are human factors and economics, systems engineering, fundamentally challenge.
Yeah.
And so I think that's why there's a resistance to any of these ideas, because it's such a profound and different way to view the world that healthcare is just not ready for it.
A lot of them things you describe, I guess, are different cultural challenges, aren't they? They're and almost you describe three different cultural challenges. One, the healthcare practitioner themselves, the system's approach to what they're doing, and their approach to, I guess, specialism, and what error fundamentally is, what failure fundamentally is. So you're almost trying to do a triple whammy at that point.
Well, yeah, and it's kind of like that. So the people come to it through things like teamwork training and starting to see, like situational awareness is a great example. That people start to see that there is, that there's a kind of there's a system surrounding what they do, and that. But if you don't go and then ask, well, where does situational awareness come from? When it comes from the devices and displays and the EHRs and all the things around us, people often don't make that step, because that step is to then say, oh, well, actually, all this equipment that I use is often broken, and the information that I get is often, incomplete. And all of those might lead to a situational awareness failure, which I've now tied to harm. And so situational awareness failure is often, people stop there rather than saying, well, where does situational awareness come from? But once you go beyond that, then you start to see the system, and then you start to say, well, hold on, actually, situational awareness is actually about how many patients I have to deal with. And how many patients I have to deal with is actually a financial and organizational decision. And so there's these kind of steps that people go through to get to, oh, now I start to see how profoundly I was mistaken when I thought that it was about how hard I tried.
That's fair. At the beginning of of your statement there, you also mentioned that you think that we as a human factors community need to change, and then he very quickly glossed over that and moved on. So I want to drag you right back to that.
Yes.
What could we be doing differently to make this better?
So there's two aspects of this. One of which is actively making change. So we're taught a lot about systems analysis, and we haven't really been taught much. I was never taught much about how you actually go about enacting change within complex systems. That what I love about clinicians, and I have a particular story about. Anyway, what I love about clinicians is they're active people doing amazing things every day. They're not sitting back and saying, well, somebody should do something different. They are the people doing the best they can with what they've got. And that's, by the way, what makes them amazing at what they do, and also how we can help and why we need to kind of meet together, because somebody is amazing at doing the best they can with what they've got, and and is doing incredible things for people. Often get focused on that, and we can say, well, hold on, anyway. So, but we need as practitioners to understand that we're part of that. That particularly in the UK system, every pound that's spent on a human factors professional is a pound that can't be spent on the treatment of patients. So we better make sure that what we do has an impact on patients. It's not just, oh, we're going to write some recommendations, or we're going to do a systems analysis. Where does that systems analysis lead? So the first thing is about taking all these tools we have and making sure that change is made, that recommendations that we make, we actually need to be actively involved in dragging those through to change. The second piece is around evidence base. That what this does is then say, well, what's the evidence? So, when I first started looking at this, I had, a surgeon say to me, well, show me the evidence that teamwork makes a difference to my outcome for my patients. So we had to go out and find out, right, how do we generate evidence around this? And I think that this is another challenge on my human factors colleagues. A lot of what we do is not really evidence-based. And there's a challenge with that. And by the way, evidence-based, I mean, have we done a study that says, have we done I sort of joked, I know human factors will have arrived in healthcare when there's a paper in the New England Journal saying, around a human factors intervention that led to, anyway. But that's the kind of level of science that we need to be trying to get to, whether we can or not, given that the evidence bases and how we go about that, and the approaches we need to take with complex adaptive systems are different. Anyway, all of the differences that we need to challenge ourselves, that what we're doing is both useful and we're not made, and it's not based on perceptions, but it's that we challenge our assumptions about what we do. I was trying to think of a good example of this. But anyway, so I think those are at least two of the things. Oh, the third thing is about how we practice. So I think that, I've talked about this and written about this, that I actually think that the practice of human factors in healthcare is a fundamentally different way to practice human factors and ergonomics, because essentially what we're talking about is having to distribute the expertise across a broad system. But hospital A and hospital B are having the same problems, but they might be on two different continents. But we need to have a human factors perspective that's both learning the common themes for me. So I know, retain foreign objects. I've got some research funding in retain foreign objects. Retain foreign objects happen everywhere. So one way in which we need to, we can contribute to improving this is having human factors professionals distributed, spreading the expertise, spreading best practice, spreading knowledge. But we also need to not be each independent reinventing the wheel. So whereas in heavy engineering, whatever, transport, Boeing, power stations, you can have, a small number of people working in, a collection of human factors professionals working in one area, all on similar problems, and they can engineer that system, they can engineer whatever, a flight deck, or engineer a process, and then, the engineering will kind of will spread without having to have that expertise. We don't have that in healthcare because every hospital is different.
Mhm.
Every hospital has the same, hospitals have the same problems, but every hospital is different. So we don't have the collections of human factors professionals that we have in the traditional engineering kind of environment. So we've got to distribute everyone, which means that we have to support people in these professionals doing this in different ways. And like Fran Eyes, for example, I think has been putting together in the UK communities of practice around this. So we've got a method of doing that in the US. So yeah, I think it's there are other reasons why I think that this is a change in human factors human factors ergonomics practice as well. Well, I'll stop there. So if we go back, I think it's about, I think the challenges are about making change, about evidence base, and around how we do the work.
Yeah, that's cool. I guess I want to spend a bit of time taking advantage of the fact of the UK US piece again. I mean, the way that the two healthcare systems are ran are very different. The UK is socialized medicine, free at the point of care, free at the point of access. The US system, when I watch the series and the things on the telly, it's obviously it's based on the insurance principles, even though we've had Obamacare and things like that as well. Do you think that makes a massive difference to what you're finding in terms of the research you do, the way that the practice happens, or is it just the biggest red herring ever?
So no, I mean, on the one hand, so even though the the funding mechanisms are very different, by and large, healthcare organizations, as far as I've seen, in the US, UK, talking to colleagues on Australia, in Europe, the same kind of frontline problems, delivery, care, everyday problems are the same. So, I sort of, one of my kind of jokes is I just sort of joke that you can make any surgeon in the Western world roll their eyes if you talk about preference cards. Preference cards being the list of things that they need for their surgery, which ends up being an incredibly unreliable process. So one of the frequent things you see if you hang around in surgery, as far as I understand it, anywhere in the Western world, is the surgeon says, "Can I have one of these?" The scrub tech says, "Sorry, I didn't know you needed one of those." And the surgeon say, "But it's on my preference card." And the scrub tech will go, "Well, it's not," or "I don't think it is." And so it's a kind of point of frustration. And there are so many different things like that. Whether that's, central line bloodstream infections or failure to rescue or retain foreign objects or falls. So these are systemic problems and not ones of, fundamentally about organization. The difference is, I think there are two differences. I think one of which is that in the US system, there is more money around. And so I think the spread of human factors professionals employed by hospitals has been better and easier, particularly if you can make a business case, because it is essentially a business. But that also leads to kind of weird, perverse incentives. And I think what I see in the UK is that there's this, been increasing reduction in funding that's been available for the NHS, which is exacerbating all these problems. And if you like, making what I've been looking at in terms of sort of systems and people and whatever designs, less important, because the increasing problem is the number of people who are available to deliver care. And that's happening in the US, actually, I think, for different reasons. But yeah, so So the problems, so the frontline problems and the kind of human factors issues are mostly the same. They might kind of look slightly different, but there are all so many parallels, which suggest that these are about the design of the healthcare system and not the funding of the system. But there are definitely differences and constraints. Another feature is that with a national system, you can spread much more the learning between organizations, and you can share the harms that have happened, and so there's greater learning. You can spread ideas quicker. Whereas in the US system, the hospitals are very reluctant to talk about the things that have gone wrong to other hospitals because they're all in competition with each other.
Right. Yeah.
There isn't the level of, which is particularly problematic for patient safety, because you've got the same, you've got injuries happening in hospital A and hospital B and hospital C and D. You might have for the same cause, and you might have a patient injured at each one of those. But if we're not sharing that information, then it just looks like, oh, it's one patient at one hospital had that problem. Those are some of the differences.
Yeah, I guess I hadn't really considered that element of competition as being a thing. The fact that in the UK, we, in busy times, you'd almost be happy to ship a patient off somewhere else to make them somebody else's problem who has much greater capacity, or to make sure the same incident doesn't happen. Whereas in the US, that competitive nature of getting in which is not, in that system, it's not a bad thing. But they've got to have that focus on, right, we've got to get the throughput in order to sustain sustain the business model. You mentioned you mentioned there as well, which I wonder if this is something that the UK could learn from the US, and that's about the business case. Because I think it's a human factors problem anyway, that we are one of these type of disciplines that if we do our job well, you'll never know we've been. It's only when things go wrong and you go and firefight the situation, you solve it. If we've been brought in nice and early on, you should never, a bit like Santa in many ways, or the Tooth Fairy, you should never know we've been. So how do you, and you might not, I might be asking you a question you can't answer, but how do you think we could develop the business cases better in order to sell the fact that you need, or people need HF intervention?
Well, yes. So this is a real problem. It relates to kind of what I was saying about the kind of evidence base too. Particularly because what we do is collaborative. That if, for example, I'm involved in improving approach to detecting retained foreign objects, that's not just me. That's a whole bunch of people, clinicians and and administrators, and and so saying, hey, human factors did this, is itself difficult. And as a as a scientist, I would find that difficult to do. I know that that's kind of an MO of people in an organization, is that within a sort of kind of business sense, to take kind of broad credit for things you didn't that was anyway, that might be more the story might be more complex than that. Anyway, so as a scientist, I find it difficult. But I think to make a business case, it's not a scientific thing, and so maybe that we can do more of that. Another way to look at it is that the problem of a business case is actually one we're experiencing more generally within the patient safety world. That as budgets get constrained and people get, and our staffing levels, don't match our ability to deliver care, then that's going to have an impact on the safety of our patients. But actually, how do we make a business case for for that, and that's a problem with the patient safety movement in the US as well, that healthcare costs are rising, and so and so people are interested in how they can get cheaper healthcare. Well, cheaper healthcare might be less safe, less high quality healthcare, but if we don't have figures for that, then the pressures are going to be to save money and not, So in fact, this has always been a problem that if you consider that healthcare systems or any system is trading off, kind of throughput with quality, with quality and safety, with cost, and you have very clear targets for the number of patients you have to deal with, and very clear financial targets, but your ability to kind of measure the quality and safety of what you do is not quite so solid, then people are going to trade, safety and quality for the other two very much harder things. So yeah, it's a problem, and I don't have a solution. I think the one way to do that is through the science. That's why I'm trying to, why I think, and science is not only about performance or reducing errors or whatever. It's also about those efficiency pieces, and I think we can do that. But I also know that decisions aren't made only based on evidence or indeed a business case. That there are plenty of people employed in hospitals for which there's no business case.
Right.
Plenty of things done in clinical organizations for which there's no evidence.
Yeah.
And so I think it's a bit more than that. Absolutely, these things are valuable, but I think that I think it's more. I think the leverage that we want to have more human factors, included in healthcare considerations, isn't just about evidence, and it isn't just about business case. All those things help.
Yeah.
But and I don't know what it is, but it's more than that, because we went and found the evidence for teamwork being important in surgery, I don't know, 10 years ago, and still we're not doing
it. Yes, no, there is that.
So anyway, but I think it's also on a micro scale, and I think that's where actually building up stories, people, ultimately people learn and change not through evidence and not through numbers, but through narratives and stories. So so building up stories, spreading the expertise, sharing good practice, rather than I'm at this hospital doing this and you're at that hospital doing that. That's a powerful thing around what I see as being this professional model of networking this expertise.
So I guess that's the case for case studies and telling the narrative, not
and
just
collecting them in some central place, or at least so that we have a whole collection of different stories and knowledge. We reduced CLABSIs, or we reduced retained foreign objects by this much using these techniques. Great. I don't need to I don't need to go and reinvent the wheel. I can take that and present that, and that's how we build up a business case. We did this in 3 hospitals. It saved this amount of money in projected costs of retained foreign objects and that kind of thing. I mean, the flip side to this, of course, is that all it takes is one really, really bad outcome, and that will pay for a vast amount of human factors and ergonomics expertise.
Yes.
But yeah, we don't want to be in a situation where we're having to learn from those dreadful outcomes. And yeah, once or twice I have been.
Yeah, no, that's fair. I guess going on that case study approach, then what do you think the most satisfying project that you've been involved in that you can share is?
One of my favorites was this thing we did. So I've been involved in tons of really cool stuff, and I sort of get to ask stupid questions. Why do we always do it like that? Is there a better way to do it? One of my favorite ones was some work we started when I was at Cedars-Sinai with trauma patients. So we were observing trauma patients. We had basically two researchers camped out in down in the emergency department who would who would as soon as a trauma patient came in, would follow the patient. And so we'd follow the patient on the different routes. So whether they were going to go to whatever CT for imaging, to the operating room, to the ICU, or whether they were just staying in the trauma bay and didn't go any further. So there are kind of different routes to how these patients would go through the system, depending on whatever gunshot wound versus a traffic accident versus somebody had fallen over, all those kind of things. And we were looking at how we could streamline the process in different ways. And so during these observations, the first thing we noticed was that the first 2 or 3 minutes after 5 minutes after a trauma call came in, so the ambulance would kind of radio in to the emergency department, right, we're bringing a trauma case in. So the first few minutes with the trauma team who had pagers, they would all turn up. This is kind of clinicians from the hospital. They'd all right. There's trauma. I've got to turn up, go to the emergency department, and then they wander around saying, "Hey, does anyone know anything about this patient coming in?" And so they and from a human factors point of view, that's kind of wasting time, because what you want to be doing is preparing for that patient, not finding out what's going on. Mm-hmm. And so we then thought, okay, well, actually, if we want to have better teamwork and we want to have better process with this, then that would be a really good thing to do. How can you improve how can you spread this knowledge of this patient coming in so that the team could prepare. And we also found that as soon as the trauma was activated, somebody from the operating rooms would phone down to the ED saying, "Do you need an operating room? We need to hold one up. Do we need to prepare one, or do we need to get this patient quickly into the operating room?" And then and then orthopedic and neurological consultants who would tend to be brought in within certain if it's certain types of accidents, would also be phoning down to the ED. So you've got tons of people wandering around, or you've got all the trauma team wandering around trying to find out who's taken the call and what's happening to the patient. All these phone calls start happening of do you need me? Do we need an operating room? Do I need to come down? And so then we thought, right, well, first thing is, let's have a whiteboard. Let's the person who takes the call from the who knows what's about the patient. Let's ask them to write some basic details: mechanism of injury, age, whatever, heart rate, blood pressure, super simple stuff, because that will help the trauma team to know what to do to prepare. It was a gunshot wound, okay. But then, of course, with whiteboards, pens go missing, things don't get wiped off them. There are kind of practical challenges with that. It's funny, it's often the simple stuff.
Yeah.
So then we thought, well, okay, well, how about an electronic whiteboard? That way, we might, we won't lose pens and we can wipe it, that's. And then we thought, well, electronic whiteboard, that could be an app. Well, if it's an app, why don't we just make that app accessible to all these people who are making all these phone calls? And so the OR now knows exactly what's happening to that patient, and so can start making their own judgments. Yes. Oh, it's a gunshot wound. We'll definitely need to be preparing a operating room. Oh, it's a fall. I don't know. Let's see what happens. Well, let's see what happens with the imaging, whether they're going to need to, same with ortho neuro. So you start distributing this information, and suddenly everyone is much better prepared and know what's happening and can respond in a much more effective way
Mhm.
than this, than the way it's happening already. So when I got to MUSC, this is exactly what we did. We did a 6-month trial, 3 months kind of pre-intervention and 3 months with using this app, and it worked really well. I actually remember being in um, we kind of went online on my birthday. I was in a restaurant on my birthday, and there was a motorcycle accident outside. And I was like, "Oh, I wonder whether this person is going to appear on my app." And sure enough, uh, about 10 minutes later, I could see exactly this patient had arrived, and they were going to CT. And so you could see, and it was this kind of incredible thing where you're just distributing this information. Visibility and the opacity of healthcare systems being, I think, one of the fundamental problems that nobody knows what's going on. So here you got an app that does that. So it's a really neat thing that our clinical teams really liked it. The people who got most benefit from it were not the trauma team actually, but the people more removed. But anyway, essentially, it was a really neat solution that ended up being a smart app technology, but was not driven by, hey, we've got a smart app idea, I wonder what problem. It was, here's a problem that we could be solved. Oh, the other piece of this is we also observed that they were kind of text messaging each other in an unsecured way. So we were able to go into, so we added secure text messaging and in fact secure imaging. And so it was a very, very simple idea that we just said, hey, try this, and they loved it. Unfortunately, there are all sorts of reasons why we couldn't eventually implement that within the hospital, but that was another. So anyway, that was one of my favorites, and we wrote it up. We didn't actually get any significant results, but all the results that we thought were in the right direction. So it improved teamwork, it improved the process, improved the speed of response for these patients. So there you go.
That does sound fun. It sounds something right up my street that I'd love to get involved with. And also sounds like a fantastic birthday present to.
And that's what you get from hanging, and that's what you get from doing this kind of deep work of hanging around in clinical areas. That you actually can go right round what seems to be a complex problem to get to a really simple idea. But you've kind of got to be there to see it, and see actually what people are doing rather than,
That whole observing and seeing, almost like the people working in their natural environment, their natural habitat.
Exactly. Yeah.
So,
anyway,
cool. Well, that's fantastic, and a really fantastic insight into your perspective from healthcare. We're going to take another quick break, and then we're going to get into the final 3 questions.
Great.
So back right after this.
Before Barry gets to the final 3, my name's Nick Rome. Let me tell you about this. Technology in our world is evolving at a phenomenal pace, and keeping up with what that means in the human factors world can be challenging. That's where Human Factors Cast comes in. Human Factors Cast is a weekly podcast that highlights and breaks down stories that are chosen by you, the Human Factors community.
New York State is giving out hundreds of robots as companions for the elderly.
Buttons in cars are safer and quicker to use than touchscreen.
A prototype just achieved a major milestone that actually fits the description of a flying car.
The show provides perspective based on experiences from different domains and different industries. We even cover some of the hottest conferences in the field. On this episode, we're recapping EHF, Ergonomics and Human Factors Conference, Neuroergonomics Conference, Human Factors and Ergonomics Society, UXPA International. Join me, Nick Rome.
And me, Barry Kirby.
Every Friday morning when Human Factors Cast drops on YouTube and your favorite podcast directory. And remember,
it depends.
And now I'm going to send it back over to Barry for the final 3.
Great. So these are the final 3 questions we ask. We ask everybody the same. What is your go-to book or a paper that you couldn't be without in your day-to-day practice?
That's funny. So let's see. The book that I actually give to everyone who works with it. So I have medical students who come work for me, and in fact, my 2 research assistants are not human factors qualified. But I've trained them up to see kind of systems. And so my book that I sent, that I tell them all to read, and we buy various copies for what we do around safety, is Sidney Becker's Field Guide. Field Guide to, I think it's called the Field Guide to Human Error now. It used to be Field Guide to Human. Anyway, which is it's not a reference book for me, but it's a wonderful introduction to this way of thinking, the system safety way of thinking, to people who haven't encountered it before. So I just think, and I've used the slides that I derived from that in talks, whatever, 15 years ago, that I've kind of built on. Anyway, so I've used that as a basis for a lot of the kind of narratives, because he's great at actually illustrating the stories and the kind of a lot of the false beliefs. So there's a great narrative. It's easy to read. It's about 250 pages, I think. And so that's what I use, for reference myself. If I need that sort of thing, I would go straight to Salvendi's I'm sorry, what is it? It's up here. The Handbook of Human Factors and Ergonomics, which is this incredibly thick and rich distillation of everything human factors. But I actually don't. Yeah, I don't need to use that too much.
Cool. If you go back in time to a point that suits you in your earlier career, what advice would you give your younger self?
That change is slow, and be okay with that. But that sustaining, and so the trick is to sustain that and find other people who who will support you when when it seems like you're not getting anywhere.
Yeah, I feel that one. And then if you go forward in time, number of years ahead, and you decide that you're going to retire, what would you like to be remembered for?
Of course, I want to be remembered for bridging the gap between human factors and clinical work. But actually, it would be supporting people in doing that, because I try really hard to give time to people and encourage people early in their careers who are just starting to explore this and maybe finding some of the challenges that I had. And so to me, from a big professional point of view, it would be that bringing human factors into clinical work and clinical work into human factors. But actually, it's more about, I think, supporting the people in doing that.
Brilliant. Ken, thank you ever so much for your time today and for the insights that you've given us. If people wanted to get in touch with you and maybe explore some of this a bit further, how would they go about doing so?
They can email me. I think you can probably find me online. In fact, it's Catchpole without the E at musc.edu, or find me on Twitter. I think I'm at Ken Catchpole. There's only one other real Ken Catchpole on Google, and he was a famous Australian rugby player. So, I'm not the Australian rugby player who passed away a few years ago. I'm the other one.
Fair enough. That's brilliant. Ken, thank you ever so much for your time. It's really greatly appreciated. And thank you all for listening and watching. Wherever you're consuming this content from, do like the content, comment on it. If you've got any questions or thoughts that's been inspired by today's discussion, do share them for us all to see, and we'll be able to go back and respond and create a conversation, because that's what this is all about. But for now, we'll say thank you again to you, Ken, and thank you all, and we'll see you on the next episode.
Thank you for listening to 1202, the Human Factors Podcast. Please do get in touch with your thoughts, questions, and comments. You can contact us on social media such as Twitter, LinkedIn, and Facebook at 1202 Podcast. See you next time. And remember, it's more than just common sense.